8 minutes after 2 o'clock, the second and final hour of 7:02 afternoons with me, Relebogile Mabotja. And I'm so looking forward to this conversation as we have a masterclass coming up. But to everybody who has sent messages from the previous hour's conversation around fathers and fathers being present, I see you, your feelings are valid, and it is a very sensitive issue. So we will dedicate some time to it. Whether you're a little boy or a little girl, maybe you're a little boy or a little girl in a very adult body and you're still dealing with all of those feelings. Now you're a parent as well. We'll definitely give that conversation some time and attention. Coming up, our masterclass, we're going to be talking about understanding partial foot and toe prosthetics. And this stuff is so fascinating for me. It is not my world. So get your notebooks out, everybody. It is time for class. Get in touch with us, 011 883 0702, SMS us 31702, tweet at Relebogile M at Radio 702 using the hashtag 702 afternoons and the WhatsApp line 072 702 1702.
702
Masterclass.
In your masterclass for today, we are talking about understanding partial foot and toe prosthetics. We're joined by Dr Ziyaad Mayet, lecturer in the Division of Orthopaedic Surgery at the University of the Witwatersrand. And we take your calls on 011 883 0702 and the WhatsApp line 072 702 1702. Doctor, thank you so much for coming. I know doctors are very, very busy.
It's a pleasure to be here. Thanks a lot for having me. Had to carve out a bit of time, but thanks for having me.
I hope there isn't a patient waiting for a toe from you that you ditched to come on a radio show.
No, fortunately, we've taken all the toes before this.
I see. The reason I'm so fascinated about this particular conversation, and I think it will be our first on a very specific part of prosthetics, we really have seen prosthetics that you cannot even tell is a prosthetic. The way that things have evolved with what we're able to do is just absolutely phenomenal, with some of the greatest people creating prosthetics coming from Africa and creating prosthetics that match different skin tones so beautifully. But before we jump into that, I want to find out from you, how did you your medical journey lead you specifically into the space?
Well, actually, I'm an orthopedic surgeon. My call to orthopedic surgery was quite literal, the Greek meaning straight children. And that brought me into orthopedics. And more than that, I'm a nut for deformity correction and kind of making things straight, getting God's children physically straight. I don't know about the spiritual part too much, but that then led me then into foot and ankle surgery more than anything else.
Ooh.
And I'm heading the unit at Baragwanath on that.
Can you just help us understand from a medical perspective with regards to, bottom half of the body? You saying you specialize with foot and ankle. Are there other specialities around the femur, knees? Like, what are the other specialities so that we have context of really how specialist your speciality is?
Okay. So everybody knows a cardiologist, all right?
Yep.
Before you're a cardiologist, you're actually an internalist. So you've got an internal medicine, you're a physician. Before that, you're a general practitioner. Similarly with orthopedics, before you're a foot and ankle surgeon, you've got to be an orthopedic surgeon. Before that, you've got to be a surgeon in general. And before that, you've got to be a doctor.
This sounds like 70 years of studying.
It's been there and thereabouts, yes.
Oh, my goodness.
Luckily, it's radio and you don't see my grey hair.
Listen, we don't say grey, we say silver.
Yes, much
silver,
better, yes.
Much better. Okay, and I find it fascinating. So now you gravitated towards foot and ankle, specifically deformities. Can we chat a little bit about some of the common ones that we already see? And if your speciality, before we get to the prosthetics part, really sits within the framing of corrections like newborns coming out with deformities and you do those corrective procedures, is that what we're referring to?
That's part of it. Others are degenerative. So From the simple bunion or hallux valgus deformities right through into flat foot, high arched feet. Those are sort of common deformities. Then we're talking about club feet that come through in the kiddies. And it's the whole range of things.
So when do prosthetics become a part of the conversation? I would assume that unless a child is born with a deformity where they don't have a foot, for example, and that you already know from the onset, that it would have been you being a part of the conversation of why an amputation might be necessary to then lead to prosthetics, or how does the process usually happen?
There's basically two forms of events that lead up to an amputation. Obviously, there's a whole lot of stuff before that, and there's reconstructive surgery and everything that can go on before that. But we have the sudden onset, and that's more than likely trauma. Some other sort of trauma that goes bad, and that then leads to amputation. Or there's been a sort of prodromal thing that comes on before that.
What is a prodromal? Is that like an infection or
So yes,
bacteria?
there's been a whole lead up through that. So the child is born with a deformity, carries on through life, and finally things go so bad that you have to then give the amputation. Infections, diabetic feet. So there's a whole host of stories that come before that. And that's really important to get into because talking about what was mentioned beforehand on the fathers, you're dealing with a whole psychological concept behind that, the psychology of the patient and loss of a body part. So there's a lot of psychology linked to that.
I want to take a few steps back. I've been fortunate enough to interview many individuals, some who were born with without, bottom parts of their legs, without feet, others who lost limbs because of being attacked by an animal, catching some kind of flesh-eating bacteria, or, like you say, diabetes related. At what point do you get the phone call to come in? Like, let's say, touch wood, I have been in some situation where the doctors have determined that they're going to have to amputate, and they present to me. Are you part of the conversation from the beginning where already it's to say, listen, this person is going to speak to you as well about what the post-life can look like and prosthetics before a patient makes their final decision? Or do you only come into the conversation once they are kind of in rehab and then they come for consults?
So the type of patient that presents to me, it's usually not an acute sort of trauma, can be, but there's usually been some sort of prodromal, some sort of set up to the current situation. And some of the time I'm actually going the route of reconstruction. Now,
Yes.
Reconstruction will mean rebuilding, regrowing the leg, etc., etc. But those also come at a cost, financial, psychological, emotional. And is your patient then ready for that? Is it not better in the patient's best interest to then do an amputation? And that's the kind of discussion and the walk you have with the patient as you go through the process.
Okay, and I think it must be extremely tough for surgeons like yourself who deal with these matters, because in as much as a psychologist is brought in, you are the one who has to break the news to the patient.
Yes, so
At times, yes.
yeah, this is probably as hard to deal with as my taxes, because I'm not trained for these kind of things. I have to learn it along the route as I go through medical school. As I went through my training, I pick these little things up, master classes from Relebogile, whatever comes into
Yes.
that, wherever I'm drawing on everything that I have, total life experience. And that then builds me into kind of a psychologist that has to sort of run the team.
And I have to say to anybody listening who has a loved one or they themselves have gone through that process of losing a limb or part of their limb. I mean, today we're focusing specifically on feet and toes. There are so many stories of people sharing their journeys on your social media now, and that's the beautiful thing about it, where they talk people through. So, Doctor, I have to tell you one of the stories I saw, and it's a pity I can't reference the person right now, but this woman had to have her leg amputated from just below the knee. I don't recall how or why, but she was sharing the journey. And then, fast forward, she was explaining that you can request your limb in America if you apply prior. She requested her limb. They did all the formal things that they needed to do, or the biohazard, whatever. They go collect it in a cooler box. And as she's telling the story, I'm like, why would she want her limb? But then she goes to say that her and her friends helped her debone, not debone, rather deflesh the limb, and they leave it in a liquid in a bucket for a few weeks. And what they are doing with her bones, she's going to have her bones brought back into something that will build her prosthetics on top. And I was like, I didn't even know that was possible. So she's going to be keeping one of her toes, she's keeping around her neck, and the bones she is keeping for her prosthetic to be built on top of her. I thought, what? This is amazing. Like, what? I thought it sounded crazy at the beginning, but wow. Are we that far in medicine, even in South Africa?
So South Africa, we are lagging behind a bit. And a lot of it's got to do more with financial reasons than anything else. We just don't have the financial clout of other countries. So bring it in, there's few and far between that can afford it, that kind of thing. So we've got to look at all those kind of factors. Otherwise, you're looking at more the general type of situation. Our orthotists in private are quite set up to go this route more than anything else. Whereas in the state sector, it's a little bit more closed in, and we don't really have that reach any there. But the thing is, the sky's the limit. You dream it, and somebody's going to think of it a few years down the line and actually make it happen.
We've got a caller that's been waiting. If you can just put your headphones on. We've got Vina from Lenasia. Go ahead, Vina.
Hi, Relebogile.
Yes.
Thank you so much for having me. I just wanted to say hello to Dr. Mayet. I don't know if you remember Amisha. He did her operation a few years ago when she was 13. He fixed her brachii metatarsia. How are you doing, Doc?
Oh.
Thanks yourself, Vina. Good to hear from you.
Good. It's nice to hear you as well on the radio, Doc. Such an interesting thing that you're discussing today. Just wanted to say that, the brachii metatarsia for Amisha, when she was, as she grew bigger, it was hard for her to wear certain shoes and that. And Dr. Mayet did such an amazing job, fixing that problem for her. So, we're grateful for that.
Did he also make you guys laugh?
Oh, yeah, all the time.
He's got such a great sense of humor. Vina, thank you so much for your call. Doctor, what is a brachii metatarsia?
Brachii metatarsia, again, Greek, brachii being short, and metatarsia, metatarsal is the foot bone in the center of the foot. And she presented with a congenital deformity where the metatarsal on the fourth toe was short and effectively the fourth toe was small.
That is so fascinating. Okay. In terms then of you now getting to the point of prosthetics, are you the one who designs and builds, or are you the architect who says, here are the plans?
No, that kind of falls more into the gambit of the orthotist or the prosthetist. So once the amputation is done, and it's my job to make sure that the amputation is done as best I can to give them the best possible platform to work from. So they will then see what I've left them and what goes on, and then they will build from there. And like we've kind of alluded to before, there's kind of two things that they actually take into consideration as they do that. The one would be form, so the look, the cosmesis of it, the skin color, the actually having toes that look like toes, all those kind of things. So to be able to wear open-toe sandals and look like you actually have a foot. The other would then be function, and that would be something that tries to mimic the action of the foot in two circumstances, and that would be one where you are standing and taking weight on the foot, and the other one would be when you are actually using it as a propulsive agent, so you use it walking and running.
In terms of the toes and one's balance as a human being, which is the toe that you can lose and it won't affect your walking in any way or the least, and which is the toe that you would lose that would cause the most damage from a walking perspective of your 5 toes?
That sounds like a mafia movie. choose which toe you want to lose.
And the reason I'm asking this is because I think about the pinky toe and how many times we stub them on, knock them on tables and hard things. But then I'm also like, as I'm walking, I'm like, okay, the big toe is the one that maybe you would never want to lose. But I feel like the pinky does have a role. Help us understand.
So effectively, if you look at a chicken's foot, you've got a tripod. Okay, the human foot has got a lot more things in between.
Like this tripod.
Exactly the same as that, holding your camera up.
Yes.
But the human foot has a lot more things in between. But the tripod is still the most important. So the tripod would be then the lesser ray or the fifth ray and the first ray.
What are rays?
So the ray, you're talking just about a toe.
Yes.
It goes all the way back. So we talked about a metatarsal, which is a little bit further back than the toe.
Yes. Okay, now I do remember this part from biology 70 years ago at school when we had to actually label. Because in essence, the part we are seeing on the external is just the outside part, but it extends into your foot.
That's right, yes.
Okay, so losing a toe is, let's say you lose your pinky toe. You haven't lost the entire toe because you still have those extended bones.
Yes, so the extended bones or the metatarsals are where the person will be taking weight, and the first and the fifth is the most important.
I got you.
The toes are generally outriggers.
What are outriggers?
So outriggers, this is more to do with biology and tents, if you want. Kind of the guy rope that sits on the outside creates a little more stability.
I got you.
Okay?
I got you.
So the toes act more as outriggers. So if you wanted to lose any of them, again, you're in the mafia movie and you've got to lose one, try and lose the center ones more than anything else.
Okay.
That also having been said, you then have a little hole in your shoe or a space. And that then needs to be filled. And that, again, is prosthetics and orthotics.
But of course, it's not like teeth where you lose one and then they move.
No, they do as well.
What?
Yes.
No. What?
So that's where we get the bunion. Things are moving.
Wait, I'm so traumatized. I was literally saying that as a joke. So you can lose a toe and then they move?
Yes, they do move.
How?
Okay. So these are not just bones. They're not just metal rods. There's a whole lot attached to them. There's joints in between. There's muscles. There's tendons. There's pulls. There's things going on around that. There's a whole lot of mechanics that go into this. And like I said, that's how the bunion comes about, because it comes through the joint and there's an abnormal pull on some of the tendons, and that pulls the toe into a bunion.
Okay. My mind is very, very blown right now because I never imagined that toes are moved. In terms then of, you've spoken about the metatarsal, and my producer generously printed some diagrams for me to remind me the parts of the foot. Before we jump into the prosthetics part, how does an amputation work in terms of, if you know this part needs to be lost due to infection, do you now cut a little bit more to be safe? Maybe just give us a guide of when it comes to the part of, okay, there's no other way, but we need to remove this foot or half of this leg, because if we don't, it's this person will either die or infection is going to spread.
Yes.
How do you then decide?
So generally, yes, you've got to go higher than where the problem is. And if you're talking about gross infection or tumors or things like that, you may even leave the thing open initially to start with, the stump, and then come back later and reconstruct and rebuild that so that your orthotist then can start working with that. So,
Help me understand. So you rebuild a bit higher, but now if you are cutting cross section of a foot, where do you get the skin to close it and cover it up?
So
if I'm making sense, because
yes.
it doesn't look like just a slice
Yes.
through a leg.
So the slice through the leg or the guillotine amputation will be done for gross infections. So you know you're going to be taking too much away. So you can go in with a guillotine amputation, try and use antibiotics and other means to control the infection and come back and close it later. So you're trying to save as much of the natural anatomy as you can.
Yes.
And that goes through into a below-knee amputation or something like that. If you can imagine that, you want to leave as much of that leg as you potentially can. That makes the prosthesis easier and easier, and it makes the patient's life easier with the prosthesis.
So how do you decide, and I mean, obviously this is quite technical, but there are circumstances where I've seen an individual's stump, I'm not sure if medically
Yes.
that's how you refer to it, where there'll be a bit of bone still there, but it is fully covered. So in that healing process, do you graft skin from the leg the portion that you've removed to close it up, or how do you close it up in a way that it heals completely?
The normal run of mill of things, you would be taking the bone at a level, creating a flap of skin, and covering that up.
I got you.
There are circumstances, like I said, infection, where you won't be able to do that.
And you said you would leave it to heal to avoid infection.
Yes.
Does it sit in a fluid, or it stays exposed in like bandage and dressing?
It's bandages and dressings, which again have a whole lot of stuff in them generally.
Yes.
We get silver impregnated dressings, for instance, which are bactericidal. They kill bacteria. So you can put that on, and there's various others. That's just one example. So there is something that you're doing locally to fight the infection, as well as through IV antibiotics.
All right, we need to head over to the news. When we come back, we continue with this masterclass. Zodidi, I see your call. I see your messages and voice notes as well on the WhatsApp line, 072 702 1702. 21 minutes to 3 o'clock, and we continue with our masterclass for today as we talk about understanding partial foot and toe prosthetics. We take your calls on 011 883 0702 and the WhatsApp line 072 702 1702 as we chat to Dr. Ziyaad Mayet, lecturer in the Division of Orthopaedic Surgery at the University of the Witwatersrand. 011 883 0702. We go straight to the lines. We have Zodidi in Krugersdorp. Hi, go ahead.
Hi, Lebo. Thanks for taking my call. Hi
Yes.
to Dr. Mayet and the listeners.
Hi,
It's just a question from my side, Lebo. I was involved in an accident in 2012, and my ankle was broken completely, and I had a constructive surgery where I've got metal plates on either side of the ankle. And I was able to do physio and recover. But of late, if I'm in a gym session or participate in a marathon, I seriously struggle the next day to walk or even to stay on my leg. I wanted to check with the doctor is there anything that could be done, or what could be the cause of the sudden pain that I'm feeling now when I'm physically active.
So let me
was not there in the past.
Thanks, Zodidi. I'm going to remind you and all the listeners that obviously doctor can respond generally because he doesn't have a full profile of being able to see other things, but could give some possibilities. And this applies to everybody. Whenever we have a medical professional in studio, we cannot do on the phone diagnoses, but doctor can give a general response. Doctor?
Yes. As mentioned, this is probably needs to be assessed with proper examination and an x-ray. But it sounds like you might be running into osteoarthritis. That's where the joint starts wearing down, and that might have been speeded up by the accident and the trauma that was around that, and also maybe then overuse with the running and things like that. But you would have to have an assessment and see from there, and you would have then surgical options put in front of you with regards to that.
Thank you so much for that question. When we look now at the part of the prosthetics, do you usually only get them fitted for use after a person has done rehab? Do you sort of like have to wait for the bones and everything to settle? And then does that happen prior to the rehab, or where does that fall in the process?
So you mentioned skin earlier, and that's probably the most important point when you can start putting on prosthetics. If you're going to put something onto skin that's horrible or onto an open wound or anything, it's not going to end very well. So you have to have skin closure. Once you have skin closure, the wounds have healed, everything has gone on. That then goes on to an occupational therapist, usually, who helps with coning. Sometimes the prosthetists do that themselves, and then they put the prosthetic on and measure you out and make it, obviously.
Please help me understand how a person who has prosthetics gets to fit them in a way that they're comfortable enough to run. We can use Oscar Pistorius as quite a well-known one. And his were blades that were fully more functional than it was about looking as realistic as possible. But how do they stay on when somebody is running? Is there something that gets like metal plates or things that get put into the leg, or help me understand?
So there is osseointegration, where you can put metal rods into the bone itself and attach that to the prosthesis. But what he had was something different. That was more the standard sort of fitting. You have a cone that the stump fits into. The cone is then attached to the leg in some way. And if you noticed, I think he had straps above where the cone sat.
Yes.
And that was effectively tying that cone onto the stump. So it's something that's higher up, that's on the leg, tied down, and that links up to the cone.
So now when we look at the partial foot and toe prosthetics, I mean, this obviously would be a lot more tricky than an entire foot prosthetic, correct? So if, let's say, you lose 3 toes or you lose the front half of the foot, where does one even begin to measure? And it sounds so complicated. Do you do like a cast of the other foot and then start to work from there to build and match?
Yes. So again, these are done more by prosthetists than anything else.
Yes.
And they would start off with molds of the other foot to try and build up what you have there. Where toes are lost, it becomes incredibly difficult, especially in the safe sector, because you just don't have the availability of the materials there. But you want something that then takes the space if you're dealing with one of the in-between toes. As we mentioned, there is movement of toes, so you want to prevent that. You want to put a little block into there. And particularly with the first toe, you may want some propulsive movement out of that. So then you would look at something, again, like Oscar Pistorius's blades that can actually give you that to some degree. You're never going to get it back. And then also shoe wear modifications to actually compensate for that fact that you no longer have the big toe to push off with.
Oh, so there are options that in the interim, while the big toe is being built, that you do something in the shoes or build something that goes in the shoes to help a person walk.
So yes, essentially, once the amputation has happened, you have to get the skin to heal. You have got to get everything to the right area. You've got to get the swelling down. You've got to get possibly coning off that stump. And that's then where the prosthesis starts getting built. And that would then go again, form or function. And what's more important to the patient? What do we have available? And all those sort of things come into the question.
We're going to take a break. When we come back, we continue. Get your questions through 011 883 0702 in the WhatsApp line 072 702 1702.
Dear Journal, day 4602 of trying to be an adult. My doctor asked me how my quality of rest is at the moment. I told him I have 2 problems. I struggle to sleep at night, but I also struggle to awake at day.
aggressively realizing your age? Get covered at pineapple.co.za. It's simple and like 19 Rand a day, so it's 100% the insurance for you. Underwritten by Old Mutual Alternative Risk Transfer Insurer Limited, a licensed non-life insurer and authorized FSP. Premiums are risk profile dependent.
Close your eyes. Taste the mist from the Sunny Pass waterfall. Feel the calm beneath the waves in Scottsboro. See the giants in East London. Breathe in the air of the Knysna Forest. Hear the roar of adventure in White River. 5 premier resorts, 5 senses, 5 all-inclusive escapes. Visit premierhotels.co.za for T's and C's and bookings.
When it comes to protecting your workforce, trust the workwear brand that has been protecting workers for over 150 years, Sweetall. Sweetall has overalls and uniform solutions for every industry, so your team is safe, comfortable, and ready to tackle any challenge. Visit our new Boksburg showroom, shop A1 Atlas Road, Westwood, Boksburg, or go to sweetall.com today. Sweetall, we never let you down. Superior protective workwear since 1871.
Nedbank Business Ignite on 702 is looking for a small business owner that talks a big game and delivers even bigger results. So if you're a small business that consistently dares to innovate, expand, and better your bottom line, you could walk away with 200,000 Rand cash and a 200,000 Rand advertising package. So enter on igniteyourbusiness.co.za. Then every day this week from 6 a.m. catch 702 Breakfast with Bongani Bingwa to find out if you're a finalist in Nedbank Business Ignite on 702. T's and C's apply. Nedbank, an authorized FSP and registered credit provider.
702 Masterclass.
12 minutes to 3 o'clock. We continue with our masterclass together with Dr Ziyaad Mayet, lecturer in the Division of Orthopaedic Surgery at Wits. And we are chatting around understanding the partial foot and toe prosthetics. 011 8830702 and the WhatsApp line 072 702 1702. We've got a voice note, Doctor.
Good afternoon, Relebogile and the doctor. I would like to know why diabetic people, some of them, they cut their foot or a body part. I really would like to know that. Thank you.
Okay, so with diabetes, why do they cut feet?
Diabetes is a disease really where there's too much of glucose in the blood in general. That then affects every organ system in the body. It gives trouble in the eyes, the heart, the livers, etc., and the kidneys. Down in the feet, what happens is that it changes a lot of things. You actually get a neuropathy where there is loss of feeling in the foot. And along with that, there's a lot of changes in the blood flow, there's changes in everything else, and that sets you up for the problems that you have with a diabetic foot.
And it's a tricky one because it happens quite quickly. I have a friend whose father passed away where diabetes complications, part of the leg was amputated, and within 2 weeks he passed away, but obviously we don't know all of the details, but it is quite serious. Here's an interesting question that says, on the internet, one can see the integration of prosthetics and robotics. Is this technology real? If so, what are the capabilities in South Africa?
So this is something that's more for the upper limb. So if you've got an amputation of the hand or the arm, for instance, then you can put on a prosthesis that has microprocessors that link up to your nerves. And that would then run the robotic arm that's attached to you. There is similar things in the foot as well, but obviously not as big as with the arm because you don't really need that kind of function in the foot. Is it available in South Africa? To my knowledge, it is not. But one would have to look into this to see, but it's definitely not in my circle.
Doctor, how many specialists like yourself actually exist in South Africa? I mean, is it the kind of thing where people have complications where they do need partial foot and toe prosthetics, wait 2-3 years, or are there enough of you around for people to be serviced in this country, be it public or private sector?
Foot and ankle is kind of a discipline that is starting off and is starting to grow at the moment. So there's a shortage of surgeons, there's a shortage of output out there, particularly in the state sector. There's always a battle going on. More than that, we cross over in and we deal a lot with the orthotists, and they also then have to keep up with us, so to speak. So as we move along, they move along with us, and we've got to keep, as part of the multidisciplinary team. And that's definitely short in this country to a big way, I think. And obviously the private sector has quite a lot more to offer. There is better orthotists out there. There's better materials and everything else. But you are limited in the state sector. And a lot of your work then gets done at places like Baragwanath Hospital, one of the major centers, and you wouldn't get it in all the secondary hospitals. So you would have to be transferred to Barra.
On average, let's assume all the materials are available. After you have now referred a patient to the person building the prosthetics, how long would it take, let's say, to build a partial foot?
If you look at the private sector, you're looking at very quickly. Within the week, you could get authorization. You could everything with a relatively simple sort of prosthesis. Your turnaround times are really not that long. You can get things done quite quickly and move as long as the people are getting paid and the medical aids are giving authorization for that. Whereas in the state sector, it's really an up and down sort of thing, and you can wait years for the materials to come in. You can be the unlucky person who's continuously looked over or passed on, or just don't make it there on time on the day or something. And other times you can get totally lucky, and you can also then get it within a very short space of time.
All right, we've got more of questions coming through. One says, "Hi, doctor. My husband has one leg shorter than the other and limps. Where do we start to get shoes adjusted for him? Is this something that a podiatrist could take care of? Or does this fall within your jurisdiction?"
So the short limb, this makes a lovely exam question.
Yes.
Where do you get shortening from? And it could be anywhere from the spine right down. So you've really got to assess the patient, see where it's going and what the problem is, and then institute whatever management you think it is. Just as a thumbsuck, if it's not a lot, there's no other problems further on, you might just want to look into a shoe raise or something like that. Alternatively, you might just look at something like a limb lengthening surgery. But again, that all goes with assessment.
Apparently, Tom Cruise has shoe raises to make him slightly taller, not because of medical challenges of one leg being shorter than the other.
Yeah, I think that's got to do more with function. He requires that little bit of height for the camera. I'm not sure, but that goes into function more than anything else. And that brings up a very interesting thing around limb lengthening surgery.
Because that happens.
Yes.
It's a thing.
Yes, we do it at Barra as well.
How much longer can you extend a limb?
Safely, we can do 4 centimeters. Anything more than 4 centimeters gets a little bit tricky. Personally, I've done up to about 9 centimeters.
What? Please show me with your fingers. So 9 centimeters is about a third of a ruler.
Yes.
That you extended someone's limb.
Yes.
So did you graft some skin from somewhere?
No, this is purely distraction osteogenesis. And again, it goes back into the word distraction. You're using distraction to grow bone. Osteo is bone.
This masterclass has made me want to go back to school. So many things have changed. All right, one person says, Dr. Mayet, considering your expertise in orthopedics, could you elaborate on the latest advancements in minimally invasive surgical techniques for complex musculoskeletal injuries, particularly those affecting joint integrity and long-term mobility? This also sounds like an exam question.
Totally. Again, we've been going on about minimally invasive surgery and foot and ankle surgery quite a bit the past few years in South Africa. But minimally invasive surgery in general is something that's on the rise. The layman probably refers to it more as keyhole surgery. We're going through smaller incisions. We're doing things through smaller incisions. We're using specialized tools like cameras and scopes and things to get around what we need to do.
Doctor, as we close off, what would you like to share with all the listeners on the subject of the partial foot and toe prosthetics?
I think the biggest thing still for me is the psychology. I think if you don't treat a person's psychology, you're actually going nowhere. So you throw the best operation at them, throw the best prosthetics at them. If they're depressed, they're down, they're out, you're not going to get anywhere. So really it's about psychology, and for me, it's tapping into what's around them and the family support system more than anything else.
Thanks for reminding us about that part, because at the end of the day, for them to do the rehab, fit it, go through the discomfort of wearing it and all of that, they have to be in the right mindset. Now we have 4 or 5 other master classes we have to do just off of this conversation. Thank you so much, Doctor, for your time.
Sure. Thanks a lot, Relebogile.
Spend your afternoon
with Relebogile Mabotja
on 702.
Let's walk the talk.